So thyroid anatomy. So point to your thyroid. Where's your thyroid?
Aquí.
Okay, and you guys are already learning how to examine your thyroid. Yay! So what do you tell patients to do when you want to examine their thyroid? Swallow, and that shows you the thyroid moving. You don't have to do that. You can actually just kind of try to pull the skin taut a little bit, and you can even sometimes see the outline of the thyroid. So the thyroid is shaped like a butterfly, right? It's bilobular, so there's two lobes, a right and a left lobe with an isthmus connecting bridge between the two lobes. And then on the back of the thyroid sits the parathyroid gland. Has anybody ever been in a thyroid surgery before? See one or shadow? No? Okay. You get the chance, it's really cool. You should check it out. Okay. So there are two cell types, follicular and parafollicular. Follicular cells are going to enclose a lumen that's filled with colloid. Does anybody know what colloid is? Remember. You guys took this, right?
Yes.
Okay, good. So colloid is mostly made of, what's that?
Iodine?
Yes, and iodine is usually paired with or connected to, bonded with what chemical? What's that? Sorry, can't you? Tyrosine, a thyroglobulin, okay? Thyroglobulin and iodide are what are going to eventually give us the thyroid hormones, T3 and T4. So these follicular cells right here, oh, is it because I touched the screen?
Yeah.
Okay. Okay, I'm going to point on this one, sorry. So these follicular cells right here, which you can also see here, right, this is the histology, are surrounding this lumen, which is filled with colloid. Colloid is mostly made of thyroglobulin, which is the precursor to all thyroid hormones, T3 and T4 really, that are going to be coming out of the thyroid gland. And then parafollicular cells are cells that deal with regulation of calcium, so we won't be talking about that today, but in your endocrinology course you will delve into that and all the disorders related to that. Okay, so let's keep going here. So I have a schematic. I don't know how you guys want to do this. Did you guys get a chance to review slides before lecture? Yeah? Okay. So should we go to our schematic? Should we draw a schematic today? Like we did last time? Mm-hmm. Yeah? Was that helpful?
Yes.
Okay. Let's talk a little bit about thyroid hormone and then we'll start with the schematic. Okay, so there are two types of active thyroid hormones. What are they?
T3, T4.
T3 and T4. So T4, otherwise known as thyroxine, and T3, triiodothyronine. You will never hear those terms being used, but it's good to know. Why is there a T4 and a T3? What's the number referring to? Exactly, yes. So the top here is thyroxine T4 and the bottom here is T3. The thyroid gland produces T4 at a much higher level than T3, right? It's about 5-to-1 ratio in terms of the production, the synthesis of T4 to T3. And the ratio at which the thyroid gland releases thyroid hormone into the bloodstream is 13-to-1, between 13-to-1 to 16-to-1. So it's releasing a lot more T4 than T3. There's actually a lot of literature that indicates that T4 may be a pro-hormone. So T3, does anybody know what a pro-hormone is?
It needs to be like activated kind of thing? Like
Exactly, yes. It needs to be activated to
T3.
to T3 to actually have biological activity, right? So what is this telling you about the body? Why do you think the body is producing a lot more T4 than T3?
T3 is up rapidly.
They're both eliminated. So it's not so much the elimination rate of T3 and T4, but think about the activity. So if I'm telling you that T3 is biologically much more active than T4, why would the body produce a lot more T4 than T3? It isn't that T3 is being used up faster, but it's because it's a much more sensitive hormone, right? What does that do for the body? So it gives it a lot more control over the effects of thyroid hormone on glands. So thyroid hormones affects pretty much every single organ in the body. I think the spleen and the testicles don't have thyroid hormone receptors, but every other organ does, right? And so having T4 in circulation all over the body and being able, and peripheral tissues having the ability to convert T4 to T3 gives organs and tissues the ability to be able to control the level of T3. So if T3 is a really strong hormone that has massive effects on the body, you want to be able to control it with a lot of sensitivity, right, and a precise degree. Does that make sense? So that's why the thyroid gland is producing so much more T4 than T3. So if you were to give T3 as a drug and you have T4, you're going to have T3 causing a lot more like labile effects. The effects are going to come more rapidly and fall a lot more rapidly. T4 gives you a lot more control over how the thyroid hormone is affecting the body. That's an important concept to get, because when we give thyroid hormone replacement, we usually give it as T4 and not T3, okay? So thyroid gland is producing 100% of T4 and about 20% of T3. And then the remaining 80% of T3 is produced peripherally by doing what?
Converting.
Yeah, how is it converting from T4 to T3? Yeah, there's an enzyme. Does anybody remember the name of the enzyme and what the enzyme does?
Adrenal and iodine?
No, you're going from T4 to T4 to T3. Removes an iodine, right. And it's removing an iodine right here. So this iodine right here on the outer ring. So removing this iodine on the outer ring, you get T3. If you remove an iodine on the inner ring of T4, you get reverse T3, which is not active, okay? Okay, any questions on any of this? So remember, T3 is about 3 to 4 times more potent, biologically active than T4. And that's why we think sometimes of T4 as a pro-hormone and not actually like a biological hormone. It does have some biological activity, but not as much as T3. Okay, so let's talk a little bit about iodine. So iodine, it's a trace element, right, in the earth. So an interesting fact to know is that inland and mountainous regions tend to have minimal iodine. So populations that have lived in these regions may have more issues with the thyroid gland. They may have what kind of an issue?
Hypothyroid.
And what else? Not so much hypothyroid, but if the
Goiter.
thyroid gland, exactly. And what's goiter? Yes. Yeah, thyroid gland enlargement, right? So what's happening is the body isn't taking in enough iodine because it's not found naturally in the resources in that area. And so the thyroid gland is going to start to go on overdrive. It's going to start to try to rev up its production of thyroid hormone to compensate for the lack of iodine, and that causes an actual physical enlargement in the thyroid gland, which is referred to as goiter. And it is the #1 cause of hypothyroidism in the world, but not in the U.S. So why don't we have this problem in the U.S. and in other? Yes, what do they put in salt? Iodine. And they also put it in other, cereals and grains and things like that. Okay, so iodine, we get it from food sources. So can we ingest iodine as a trace element?
No.
We ingest it as, what's that?
Isn't it in contrast?
Sorry, I can't.
Isn't it in contrast?
What do you mean by contrast?
Like radiology, iodine is contrast?
Oh, yes, yeah. So iodide is used as a contrast material in radiology, yes. So iodine is really volatile as an element. If you think back to like periodic table and all that kind of stuff. So we take it in as iodide, right? So when you see the I with the little minus there, okay? So we ingest it as iodine. So it's basically iodine is oxidized to iodine. You can also apply it topically. You can use it as radio contrast material. There's a lot of uses for iodine. But the main takeaway point here is that it is essential for thyroid hormone synthesis. And without it, you can have lots of problems. Okay, so we're gonna go to our schematic. I will leave this slide up so you can cheat from your desktop. Okay. So, okay. Plasma. And then this is our follicular cell. And then this is colloid over here. Okay, so what's the first step in thyroid hormone synthesis? Try not to look bad. It's up there if you need it. Yeah, so we take in iodine. Does anybody know how much, like what the US FDA recommendation for daily intake of iodine is? No? Yeah, 75, good. 75 what? Micrograms, yes. Okay. So we ingest it, and then the vast majority of iodine goes to the thyroid gland. So actually, the thyroid takes up 75 micrograms daily. So how does the iodine get into the thyroid gland or into the follicular cells? Yes, and what is that symporter called? Here's our ingested iodine. Okay, so it's called NIS for short. Sodium iodide symporter. Okay, so as you transport iodide in, I think sodium comes out, or you guys can correct me if that's, I don't know, I don't remember. But okay, so we have our little iodide molecules here. Our follicular cell has taken it in, okay? And then it's really just gonna diffuse across the cell wall, to the apical surface of the follicular cell. So this is our apical surface here. And then it's going to basically go into colloid in these little vesicles that are usually kind of stuck to the apical surface of the cell. And the iodide is going to get what? What's going to happen to it? Yeah, it's going to get, I heard oxidized. I think somebody said it. Okay. And what's oxidizing iodide? Yeah, say it. I heard somebody say T something. TPO. Okay, so let's use another color. So we have TPO here. What does TPO stand for? Yes. What's the O? Look it up, look it up. Okay. TPO is important to remember because body can form antibodies to TPO and cause problems with thyroid hormone synthesis. And again, I'm not going to get too much into the clinical and the pathophysiology of thyroid diseases, but again, something to remember. Okay, so what happens to our oxidized iodine? What's the next step after oxidation?
Where it gets oxidized in the follicular cell?
It's probably happening in the colloid. I know the book, I think, said follicular cell or something.
So what's happening here? The transporter is just getting it.
The transporter is getting it from serum, from plasma, into the cell itself. So within the thyroid gland, you're going to have cells. You're going to have, the vasculature running through, right, arterioles and whatnot, and it's going to basically move from the vessels into the cell itself.
So it doesn't move out
Yeah.
of the cell.
It just diffuses across the apical surface. Yeah, yeah. So if the thyroid is sensing that it needs more iodide, it's gonna diffuse across. Basically, it's gonna go down a gradient, right? So, okay. So what happens after oxidation?
It binds to the thyroid.
Yes, and what's that called?
Ionization?
It's called organification. Again, you don't have to really remember these terms, but if you need it, it's there. So what's the enzyme that's also stimulating this process? It's also TPO. So I'm sorry, it's TSH. So not an enzyme, the hormone coming from the pituitary, right? Okay. So organification is combining with thyroglobulin, and it's going to produce what now?
MIT and
MIT.
Good. Okay, so let's see if I can draw this. This is a very rough schematic. What's the difference between MIT and DIT?
one versus two.
Exactly, yes. And what makes up T4 versus T3?
3, 2.
So T3 is made up of
Three
3 iodides. So one MIT and one DIT make up T3. And T4 is made up of
2 dids.
exactly 2 dids. Okay. So I may need to modify my follicular cell here. Okay. So when we say that sorry, this is incorrect. This should be 2 DITs.
Okay.
Sorry.
Or just gonna.
Is there a way to turn off the?
I don't think so.
No. Okay. So that should say 2 DITs, not MIT. Okay. Whoever catches my mistakes, I owe them candy. So I owe you candy from last week, and I taught this one. So myself. Okay. So this is catalyzed by what? The coupling of the MITs and DITs to T3 and T4. TPO again, yeah. So again, I'm trying to highlight things that you will find useful for endocrinology. I don't know if you guys take it next. Is it next semester? Okay. So I have DIT and MIT. I'm gonna put. You can come and look at this during the break, I guess. But I'm basically just writing DIT and MIT, where I put the little schematic for each. And then here I'm gonna have T3 and T4 with 4 iodide molecules. T3 with 3. Okay, so we've gotten to coupling. So now when the thyroid gland wants to release thyroid hormone into the bloodstream, what's going to happen is it's going to start kind of sucking up pieces of colloid into the follicular cell, and the lysosomes in the follicular cells are going to start to break down these molecules, okay? So we have our little lysosome plus our colloid bubble, okay? And then what we're getting here is proteolysis, right? So I can draw all these little things. Sorry, I'll move out of the way in just a second here. Okay, so that's going to basically release into DIT, MIT, which is essentially iodine that's going to be reused, right? And then you have T3, T4 that is going to go into plasma to have its effect on the body, right? And then, so now you have T3, T4 here. And then in the peripheral tissue, T4 becomes T3. And what was the enzyme? It's pretty good if you remember the numbers.
Iodine?
Yes, exactly. So, and there's a few of them. There's a few different enzymes. So I'm just going to put deiodinase enzymes. I think there's 3 of them, D1, D2, D3. Okay. So, and then I'll put here peripheral tissue. Okay. Does this make sense? Pretty clear, right? And should be a review for the most part. Yeah? Okay. So let's talk about, yes.
Do you mind saying that whole thing again, like completely?
Okay, yeah. Let's go through it. So we have dietary iodine that's been ingested, right? It's iodide is the form, the chemical form that it's in. It's going to basically enter the follicular cell through the NIS, which is a transporter or a symporter, which I can't remember if it takes, as iodine goes in, sodium gets pushed out, or if both go in together. Both go in together, okay. So there you go. Iodine is going to basically diffuse across the cell to the apical surface and then diffuse into colloid. It's going to enter little vesicles that are on the apical surface of the cell, and then the iodine is going to get oxidized and organified really quickly, and basically combined with thyroglobulin into MIT and DIT molecules. Okay, MIT and DIT molecules are going to be coupled. So 2 DITs produce T4, 1 MIT, 1 DIT produce T3, and they're going to be stored in the colloid. And then when the thyroid gland needs to release thyroid hormone, these follicular cells are going to take up little chunks of colloid. They're going to ingest them, and then the lysosomes in the follicular cells are going to break down colloid into T3, T4, and iodine, essentially, that's going to be reused in this cycle, okay? T3, T4 are going to go into plasma and do their work. Does that make sense?
Yeah.
Okay, so let's talk about the drugs that you guys should be aware of. So let's do maybe orange. Okay. So there are a group of anions, let's call them iodines, and we'll talk a little bit about them in a bit, but they competitively inhibit the NIS. What does that mean if they competitively inhibit NIS?
They don't completely block it, they just.
Yeah, so does that mean?
What's that?
They just.
They reduce this one?
Yeah, we'll get to it in a second, but what does that mean that they competitively inhibit this SIMPORT?
They compete with.
They
iodine
compete with
in getting to
iodine, exactly. And that means that there's less iodine that's going into the cell to produce thyroid hormone, right? So we're gonna put here, I'm gonna just put the little negative to mean inhibition. And then, so these are gonna be like thiocyanate, for technique, I don't even know how to pronounce most of these, perchlorate anions. So if you want to think of them as anion group, anions. Okay, so that's one group right there. What's another major group of drugs that hopefully you reviewed a little bit before you came to class? It's a really important group for hyperthyroid. Yes. So thioamides or thionamides, you can say them either way. What are thioamides inhibiting?
The synthesis of thyroid hormone?
Yes, but which step? What's that? Organification and oxidation, essentially. So let's put thioamides over here. So they're going to inhibit oxidation, organification. Okay. They inhibit also another step. What's that? Sorry, speak up. Okay, yes. It's a minor mechanism of action, but that's very good. Do you know which one of the thioamides that does that?
PTU?
Yes, PTU, very good. Okay, so we'll put PTU, and I'll put thioamide in parentheses just so you can remember. Okay, it also inhibits coupling as well. Okay, so you can think of it as inhibiting TPO, right? The 2 steps that it's involved in. Okay. Anything else? So there are a few other. So this is the major stuff that I would remember. Some of the minor things. So beta blockers. and steroids, which can be used as kind of ancillary or adjunct therapies in hyperthyroid to help with the symptoms of hyperthyroid. So the drugs that treat hyperthyroid, that treat high levels of thyroid hormone in the body, they take weeks to start really having a therapeutic effect. So sometimes we'll give patients beta blockers or steroids to help decrease the effect of the thyroid hormone on the body and help with the symptoms of, rapid heartbeat, tachycardia, sweating, anxiety, upset stomach, those kinds of things. And they really help block the peripheral conversion of T4 to T3. So beta blockers, steroids will also do that. As well as a drug called amiodarone. Have you guys studied that drug yet in cardiology or? Yeah. Yes?
Yes.
Okay. Okay, so amiodarone can have really significant effects on the thyroid gland, and that's definitely something you want to remember about amiodarone, both for just clinical practice and for your board. Okay, so I think we talked about everything that I wanted to cover. Oh, TSH. So TSH affects like almost every step in this synthesis pathway. But two things that I'd want to highlight is TSH causes gene expression of TPO. So it's going to have an effect. So TSH, where's TSH coming from? Yeah. Anterior or posterior?
Anterior.
Yeah, good. Okay. So it's going to cause gene expression of TPO. But really, you can think of it as doing all of this. So, okay. Any questions? No? Okay. How are we on time? Okay, so let's go through these. So we did this. We talked about peripheral synthesis of T3. So there's 3 enzymes that catalyze this reaction, D1, D2, and D3. And they basically are, depending on the enzyme, they're found in different sites in the body, different organs, and they produce varying levels of T3. So, and then D3 produces reverse T3. So it deiodinates T4 on the inner ring, and it gets reverse T3. Okay, so I'm gonna kind of go through these, see if there's anything else. So in circulation, like all hormones, they're bound to proteins. Thyroid hormones are mostly bound to thyroid binding globulin, and again, hopefully ringing a bell. They're also bound to albumin, but albumin has a lower affinity. Even though there's much more albumin in the body, it has a lower affinity for thyroid hormone, and so thyroid hormone is going to be bound mostly to thyroid binding globulin. If it's bound, it is not active, right? So it's free hormones that are the active hormones. There's lots of things that mess with our binding globulin levels in our body, right? And so again, the thyroid is going to ramp up if it needs to. So if there's a lot more thyroid binding globulin in the body from estrogens, birth control pills, from whatever, pregnancy, so thyroid gland will ramp up to produce more thyroid hormone, so it maintains the free levels. So free levels are usually, in a physiologically normal person, free hormone levels are maintained within a very narrow parameters. Thyroid binding globulin levels with bound hormone can fluctuate quite a bit, but it has no physiologic effect. So again, another way of auto-regulating, right, the thyroid hormone in the body. Okay. Let's see. This is talking a lot about the metabolism. What do I want to highlight? You guys don't need to memorize numbers of micrograms, but it's there just so you have an idea of how much thyroid hormone is being produced, and then how much of it is being degraded on a daily basis. So you were talking about how T3 is degraded a lot more rapidly than T4. And then it's excreted, biliary excretion, and some of it goes through the enterohepatic circulation, so it may be metabolized and then re-enter the body, okay? Okay, we talked about, okay, mechanism of action on the tissue. So we didn't talk about this. So does anybody know how thyroid hormones have an effect on cells? What is it like the over?
Like stimulant.
What does it stimulate in the cell? No, so that's an effect of thyroid hormone is, yes, increases metabolism in the body. But what are thyroid hormones? What's their mechanism of action within one cell? So a thyroid hormone binds a thyroid hormone receptor, and where is it binding that receptor, and what's the, on a cellular level, what is it doing?
Gene expression.
Yes, it's affecting gene expression, exactly. So this is really important. You don't have to remember all the exact details, but just know that it's actually affecting gene expression, and that's how thyroid hormones are having their effect on the body. So let's see what I want to highlight from this slide. Okay, so thyroid hormone is going to enter through active transporters into the cell. T3 will enter the nucleus of the cell and bind to specific receptor proteins. Again, this is where T3 has a higher affinity for these receptor proteins than T4, and that's why T4 is thought of as a prohormone, and it basically alters gene expression in that tissue. And then I talked about a little bit about how there's two subtypes of thyroid receptors. Again, built-in sensitivity to thyroid hormone right there as well in terms of the two subtypes of thyroid receptors. But I'm not going to get into it too much. So you can review this slide on your own time. Again, it's there just so you know. Okay, so what does thyroid hormone do? So this is what you guys are referring to in terms of metabolism. So anytime a baby is born, we check their thyroid gland function, right, on the newborn screen. And why are we doing that? Why is thyroid hormone so critical? Exactly, yes. So it's very, very critical to brain and body development in infants and children. Iodine deficiency in certain parts of the world is maybe the number one reason for having children who are growing up with severe cognitive disabilities. So, and it's such an easy thing to fix, right? So, and so it's something that I think most of the world has caught on to, but okay. I'm not going to get into too much detail. You can review a little bit. So I mentioned how there's thyroid receptors on almost all organs except the spleen and testes. So that just gives you a sense of how globally the function or the effect of thyroid hormone is on the body. So it has metabolic effects, calorigenic, so consumption of calories, oxygen consumption generating body heat, so thermal regulation, cardiac effects definitely, so it can increase heart rate and contractility, and the cardiac output of the heart. Growth, we talked about that. It can also stimulate bone development, and it can affect the GI tract in terms of motility. So I'm kind of just, again, really global overview of the thyroid hormone effects on the body. So you know why we give thyroid hormone when we give it. Okay, so how is thyroid hormone production regulated? So we talked about TSH coming from the anterior pituitary. What causes TSH to be pushed out into the bloodstream? What's stimulating anterior pituitary? TRH, and that's coming from the hypothalamus, yes. So I'm sure you guys have talked a lot about HPT and HPA axis before, yes? Okay, so again, won't talk too much about it, but just knowing that there is a negative feedback loop, right, from the thyroid gland in terms of T3 and T4, negatively going back and inhibiting the production of both TSH and TRH. And then there's also autoregulation of the thyroid gland called the Wolff-Chaikoff effect. Did you guys talk about this? No. Okay. So when there are very high levels of iodine, you get inhibition of organification, okay? Again, it's just another way that the thyroid gland can auto-regulate itself outside of this, the hypothalamus and pituitary axis. So you can get inhibition of organification. And then the Wolff-Chaikoff effect refers to how a normal gland can escape this mechanism of inhibition of organification after a certain amount of time has passed. Okay? And then there's obviously lots of other things that are affecting the peripheral conversion of T4 to T3 as well. Yes?
So what determines what feedback mechanism is adopted by the body, whether it's the HPT or the...
You're gonna have everything battling each other. So, yeah. So, I mean, so just in what we consider like euphysiology or normal physiology, you're gonna have balances between all of these so that you have that constant free hormone level in the body, right? But then you're gonna have outside stresses, right? Whether it's, we think in extremes in terms of US, like starvation or severe illness, that will sometimes override some of that normal physiologic regulatory mechanisms and will cause dips in thyroid hormone levels, but then the body will compensate and come back. Does that help answer the question? Like you're wondering what's the major regulatory mechanism?
Yeah, like is there a major one, or is there a particular time when the autoregulation is adopted versus the, because I've never, I mean, we weren't taught about the autoregulation,
Sure.
so I'm just wondering if...
The major one is the HPT. Yeah, that's going to be your major one because there's lots of things that are going to be affecting the hypothalamus, right? Sorry, I keep forgetting. So you're going to have lots of things that are going to be basically inhibiting or promoting the synthesis of TRH, not just thyroid hormones. And so I would think of this as the major one. You can think of this as minor in the sense that if the body is getting too much iodine, then the thyroid gland knows how to deal with that situation. Yeah. This sometimes will be overridden though by severe stresses. So if somebody is severely ill, if somebody has very poor nutrition, something like that, sometimes this won't function correctly. And so meaning that they won't have the normal thyroid hormone levels in the serum, in the plasma. So just really briefly, spectrum of disease, we have hypothyroid, hyperthyroidism. We have, so what's the difference between primary, secondary, tertiary? Really brief. So when I say primary hyperthyroidism, where's the problem? In the thyroid. And secondary? Okay, and tertiary. Yes. And the predominant one that you're going to see is primary, right? And then you can have overt or subclinical. Does anybody know what the differences are between those two?
Symptom-wise?
Yes, symptom-wise, and really so overt you're going to have symptoms. Subclinical you won't have symptoms, but you will have some laboratory abnormalities. And then euthyroid 6 syndrome, so that's what I was referring to. Sometimes in severe illnesses, patients can sometimes have a decrease in their thyroid hormone levels, and then again the body will rebound, and then you can obviously have the neoplasm, both benign and malignant, related to the thyroid gland. So, euthyroid 6 syndrome, hopefully you'll talk about it, but sometimes in the hospital you'll randomly check TSH and a T4 on a patient. You'll check their thyroid hormone levels as well as the function of the thyroid gland with TSH, and it won't be normal. So you'll think they have hypothyroid when they really don't. It's just there's stress on the body in terms of the illness that's causing the thyroid gland to not be able to produce as much thyroid hormone. But then they will usually rebound and go back to normal after that illness has resolved. Again, don't memorize this. This is just to know, right? This is to give you context to what we're talking about, and hopefully help you out a little bit in, in endocrinology. Okay. Hypothyroidism. So I put there increased TSH and low free T4. These are lab values that we check in patients. And somebody who has hypothyroidism will have an increased TSH level. So they're going to be producing more TSH because the body doesn't have enough thyroid hormone, right? Doesn't have enough free T4, and so it's going to be, right, that negative inhibition is going to be less and their TSH level will be higher. Does that make sense? Yes. Okay. I don't need to memorize this, but I mean, you can see the amount of causes that can result in a hypothyroid picture. I would be aware that in hypothyroidism, patients who are symptomatic tend to have these very non-specific symptoms, right? Fatigue, lethargy, kind of feeling out of it, tired, cold intolerance, weight gain, constipation, change in their voices, and dry skin. So think of somebody gaining weight, just, like how they go. Yeah, they can't get up too much. Okay. So we have talked about we really talked about, in terms of pharmacology, what the treatment for hyperthyroidism already, in terms of the mechanism of in terms of mechanism of action on the cells, and kind of in terms of the peripheral tissue, conversion of T4 to T3. So we'll go through these medications a little quickly. If you have questions or if I'm going too fast, let me know. But in terms of treatment, I'm going to be focusing on levothyroxine, which is T4, the synthetic preparation of T4. And then the other ones, I would be aware of them, liothyronine and Liotrix, which is a combination of T4 and T3 in a fixed dose. And for the most part, most endocrinology societies around the world don't recommend that clinicians use T3 or combination doses, but they can sometimes have specific usage. What's that?
I was agreeing that levothyroxine is the most used.
Yes. Yeah, you will see levothyroxine known as Synthroid. Yeah, does that ring a bell for some? Okay. And then there's animal preparation, desiccated thyroid. I've never seen that being used here. But it does exist and it is used in the world. Okay. I put this up for your information. It just gives you kind of overview of the differences and characteristics of these different thyroid hormone preparations, their brand names, their average doses, which we'll talk about a little bit. So Liotrix is a 4-to-1 mixture of T4 and T3. Do you wonder why it's in a 4-to-1 mixture when the thyroid gland is releasing T4 to T3 somewhere between 13:1 and 16:1, right? Like, why don't we have a combination dose with that kind of a ratio, maybe more physiologic? So if anybody wants to figure out the story behind that, you're welcome to tell me. But this is one of the reasons why these combination doses are not really recommended. They do exist, and some patients feel better on them. So you'll give a patient T4, and they'll just keep telling me, even despite their lab values becoming normal, that they still feel tired and not lethargic and not able to do things. And sometimes, and this is more with an endocrinologist as a primary care physician, I've never put a patient on T3 or a combination dose. Some patients will just tell you that they feel better on T3. So, okay. So T4, so it's a first-line drug for hypothyroidism. So it's rapidly absorbed from the small intestine. It's very cheap, and it's a very stable compound. You can keep it up to 2 years in a dark bottle. And it has a lack of allergenic proteins, so meaning that most people will not have some kind of allergic reaction to its preparation. So onset of action, so about 3 to 5 days to start working, but its therapeutic effect takes weeks. So a patient will not feel better right away on this drug. It'll take them about a month and a half before they'll start to say, okay, I feel like this is working, right? And that also tells us that we don't want to change the dose of thyroid hormone until we've gotten past that about 6-week mark in a patient. You're going to adjust T4 based on both lab value and the symptoms of a patient. this is a really important point with levothyroxine, this next one, which is that there's this wide range of oral bioavailability. 40 to 80% of the drug, when it's orally ingested, is available biologically. And why is that?
You're supposed to take it on an empty stomach,
Okay, yes, so why are we taking it on an empty stomach?
because you'll make sure you get more of it.
Exactly, yeah. So its absorption is affected by so many things. One of them is food. But it can also be affected by other drugs, by your pH levels in the gut. And so that's why we have this wide range of oral bioavailability of this drug. Usually we'll tell patients, take it 60 minutes before breakfast. So like, just first thing, you wake up in the morning, you take your Synthroid, you wait a little bit, right? By the time you're ready to eat breakfast, hopefully it's been absorbed. Or 3 hours after a meal, but most of the time patients are taking it in the morning. In terms of its metabolism, it's similar to your endogenous T4 and T3, basically. Its half-life is about 7 days. Synthroid is usually given daily, but it can be given up to weekly because of its half-life, okay? And then excretion is mostly the urine, about 80%. In terms of dosage, so you don't need to know numbers, but again, they're up there just so you have a reference. For most patients who are healthy and younger than 50, you're going to follow kind of this generic replacement dose of 50 to 100 micrograms a day. I tend to, depending on their lab values, I will start anywhere from 25 to 100 for a patient. And then you titrate up and down based on their lab values and their symptoms, as you go through the next few months. And for most patients, it's very easy to find a happy medium where they feel good and their lab values match how they feel, and they stay on that dose pretty much for the remainder of their life. What you want to take away from this is that patients who are older or who have heart disease, you're going to start lower and you're going to go slower because thyroid hormone can have severe effects on the heart. And so anybody who's older, over the age of 50 is at higher risk of heart disease, right? And anybody who has heart disease is already at higher risk of heart disease. And so you're going to start lower in these patients. You're going to start at a lower dose. In terms of adverse effects, this is a really well-tolerated drug, and if you go low and slow, they should not have adverse effects. But what would be the adverse effects if they're getting too much Synthroid? Exactly, the symptoms of hyperthyroid, yeah. Okay, so we talked about monitoring. Once they're euthyroid, which means once they're kind of normal thyroid function, you can check every 6 to 12 months. So I've had patients where I just check them once a year and it's done during their physical and that's it. And then in terms of generic versus brand, ideally patients should be on the same brand, whatever that is, or the generic form. They shouldn't be switched from one to another just because of the way that each drug is made. There could be slight variations in how that patient absorbs it, how they metabolize it, etc. And so if you're having to switch patients, if a pharmacists usually know this, and pharmacies usually know that they will be giving the same type of levothyroxine, whether it's Synthroid or another brand, but it's something to be aware of. So if a patient basically doesn't have a goal TSH level, and you've already prescribed Synthroid and it's been, 6 months, what's going to be your first thought as to why their TSH is not at goal?
They're not eating it on empty stomach.
They're not, what's that?
I'm not taking it on empty stomach.
Yeah, they may not be taking it properly, right? Whether it's on an empty stomach, daily, or whatever you've prescribed, they're not taking it properly. And that's a lot of times the major reason why we don't see the effects that we thought we would see when we prescribe a drug for patients. So a lot of times they don't take it the way that we want them to take it. And if anybody's been on medications for longer than just what antibiotics are prescribed for, you know why, right? So remembering to take birth control pills can be a headache for those of us who have been on them. So think about it then if it's a drug that, like your thyroid gland, not to minimize birth control pills. I do research in women's health, but I mean, you know, things that your body is relying on for its function. Okay, T3. So T3 we already said is much more potent than T4. Same with the synthetic. It's rapidly absorbed and it has a very high bioavailability, regardless of how it's taken, whether it's food or not. Its onset is a little bit quicker, so actually a lot quicker, 2 to 4 hours. Its half-life is 1 day, so this means that it requires multiple daily doses for many patients. It's also more labile, so it can cause fluctuations in how sometimes the patient feels or even in the thyroid hormone levels. And there's a higher possibility to cause hyperthyroid symptoms with T3. So these are really reasons why thyroid T3 isn't usually given as the medication of choice for hypothyroidism. The one big indication that it's sometimes used for is for short-term suppression of TSH, and that's usually before like a thyroid surgery is done. In terms of its adverse effects, again, they are what you would consider to be hyperthyroid symptoms. So moving on. Then there's the combination. We talked about that. There's nothing really else that I want to add. There's desiccated thyroid extract. We talked about that. And then is there a role for T3 in treatment? I just put this slide in there so that you're aware of kind of the conversation and the debate that's going on between clinicians about whether to use T3 or not. But it's not something that I will test you on, but just be aware that it exists. Okay, then we talked about the adverse effects of thyroid replacement. Okay. We talked about treatment target. You don't need to remember the numbers, but just knowing that you can overtreat and or undertreat very easily. So that's why monitoring every 6 weeks until you reach that happy place, and then after that you can space out how often or how frequently you monitor. Okay, and then I talked a little bit about this in terms of the thyroid binding globulin. So if you guys remember, I said that there are things that can increase or decrease the concentration of thyroid binding globulin. So estrogen, pregnancy, oral contraceptive pills can increase it, right? And that causes a shift from free to bound. In a normal thyroid, the thyroid gland will just amp itself up and compensate for that increase in binding globulin. In hypothyroid, what would you need to do? In a hypothyroid, the patient who's on Synthroid, now they're pregnant. What do? Yeah, you're gonna up the dose, basically. Yeah, so you will up the dose. And then there's also effects on the metabolism of T3 and T4 with other drugs. Similar situation in the euthyroid gland, it's going to compensate for it. In hypothyroid, you're going to need to increase or decrease depending on whatever drug you're giving, if it's going to increase or decrease the metabolism of T3, T4. Okay, hyperthyroid. So we'll talk about hyperthyroid and then we'll take a break. Yeah, we're almost there. Okay, so we talked about the symptoms. So the big drugs to remember here are the thiamides or thionamides, same thing, and then radioactive iodine is the other takeaway for this treatment as well, for hyperthyroid. Okay, so in the thionamides, we have PTU and MMI, propyl thiouracil and methimazole. I would remember that these are drugs for hyperthyroid. You do need to know the names. MMI is considered much more potent than propyl thiouracil, and it's the drug of choice in most patients who have hyperthyroid. The reason being, not just because it's more potent, but because propyl thiouracil has a black box warning for severe hepatitis. We reserve propyl thiouracil for first trimester use in pregnancy, thyroid storm, and if a patient can't tolerate methimazole, basically. There's a third thiamide that's available outside of the US. You don't need to know that, but it's there. And then same with hypothyroid, we usually monitor TSH after a period of time, about 4 to 8 weeks. Sorry, to check. And then about 4 to 8 weeks until they become euthyroid, hopefully from the drug. So we talked about mechanism of action. The major mechanism of action is that it inhibits TPO. Minor is that it can also block coupling, and propylthiouracil also has an effect on peripheral conversion of T4 to T3. Anything else that I want to talk about here? Okay, one thing to remember and to kind of help remember the mechanism of action and the fact that the time it takes to therapeutic effect can be kind of slow is because it affects synthesis, right, of the thyroid hormone. So it's going to take some time before the production of thyroid hormone, the effect of the drug on the production of thyroid hormone. So it's going to take time before you see the level of thyroid hormone drop because it affects the synthesis of the hormone. Does that make sense? Okay. Basically, you have a few weeks before T4 stores are depleted in the thyroid gland. So I mentioned I have a little bit on dosing there. Again, you don't need to know the numbers, but they're there for reference. In terms of its pharmacokinetics, so the thimerosal is completely absorbed and it accumulates quickly in the thyroid gland, but its excretion is slower than propylthiouracil. Propylthiouracil is also rapidly absorbed and it accumulates in the thyroid gland. I don't know, is there anything else that I don't need to read off my slides. You guys can do that. If there's any major points, let me see. The pregnancy, let's talk about that. So both can cross the placenta and can concentrate in the thyroid gland of the fetus, right? So you risk the fetus developing hypothyroidism. The reason why we like to use propylthiouracil is it's protein bound, so less crosses the placenta. And as such, there's a lower risk of fetal hypothyroidism. So despite the black box warning of propylthiouracil, they are more likely to use it in pregnancy because of this, okay? And then just, being aware that both can be secreted in low concentrations in plasma. Okay.
So does that mean that in the second trimester we switch them to metronidazole?
So I don't treat patients who are pregnant with hyperthyroidism, but I want to say yes. But let me look it up and I'll get back to you. Okay. So I listed kind of the toxicities that can occur, so adverse reactions. I listed minor, rare. Okay, the one point that I want to make here is the most serious reaction that can be caused with thiamide, which is agranulocytosis, and it can be fatal. So what do we do? What do you do?
Give them something to boost their white blood cell count?
Yeah, but what can you do while you're giving the drug?
Monitor.
Yeah, you can check CBC, right? You're gonna have a higher risk of this in older patients, those who are taking higher doses, so it's a dose dependent, and then it reverses when you stop the drug. We talked about the hepatotoxicity, and then I listed a few things there that you guys can review. Anion inhibitors. So we talked a little bit about how these work. But these are not really used anymore because they have a risk of aplastic anemia. So I would be aware of their mechanism of action and just why they're not used. And then iodides. So these were our go-to drugs before thiamides were synthesized in the 1940s. So Lugol solution, you guys heard of Lugol solution? Potassium iodide, no? Okay. So you'll see them being used sometimes on the ward. But these guys basically inhibit organification and hormone release. They can only be really given for a few weeks because of, do you remember what? That Wolff-Chaikoff effect. Sorry, no, I'm misspeaking. So basically what will happen is, it can escape, the thyroid gland can't escape from the iodide block, so in a matter of a few weeks. So basically you can use iodides to decrease the levels of thyroid hormone, but you're going to use it for a short term, basically. So maybe they're going to be going on to surgery, or they're going to use a radioactive method. So if you want to decrease the levels of thyroid hormones rapidly and for a short time, you can use iodides. I've never seen iodides really being used in clinical work. I think just knowing that they exist is the main thing. So thyroid storm. Has anybody heard of thyroid storm? So thyroid storm is like a really severe form of hyperthyroidism where a patient can become severely ill and end up in the hospital. So iodides could be used in that situation to help rapidly decrease the levels of thyroid hormone that's in the body. Okay.
You said thyroid storm is a severe hyperthyroidism?
Yeah, you can think of it as a very severe form of hyperthyroidism where a patient basically will end up in the hospital. You can use, so remember thiamides, they take weeks to work, right? They're going to take about 4 to 8 weeks. So iodides will work immediately. In terms of the adjuncts, so we talked about beta blockers and glucocorticoids and how they can be used to relieve the symptoms of hyperthyroid. They are not an actual treatment for hyperthyroid, they're just to relieve the symptoms. So sometimes you'll have a patient who comes in, you diagnose hyperthyroidism in this patient, and then they're just constantly feeling jittery and on edge and anxious. We use beta blockers frequently to help with those symptoms, to decrease, to help that patient feel better. And then once the thiamide and the thiamidol has kicked in, we'll stop the beta blocker. We'll get them off of it. The same thing with steroids. Steroids can also be used, but beta blockers are going to be your go-to for this. Okay, radioactive iodine, just also again briefly. So has anybody heard of radioactive iodine? Know anybody who's ever needed to take it? No. So a lot of times in hyperthyroid, and you'll get into the details of this more in endocrinology, but a patient will be on methimazole for a while, and instead of having them be on it forever, we will give them radioactive iodine, which basically destroys the thyroid gland to some extent, and then they become hypothyroid, and then you give them Synthroid. It's a really weird way to treat hyperthyroid patients, but it's easier for a patient to be on Synthroid than it is to be on methimazole. And so a lot of times endocrinologists will go down that route for a patient with hyperthyroid. So in terms of radioactive iodine, it's given either as an oral solution or as a pill. It's rapidly absorbed, and it concentrates in the thyroid follicles. The parts of the thyroid gland that are hyperactive are going to take up more of this radioactive iodine. And basically, this radioactive iodine, it's radioactive, it's going to be emitting beta rays into the thyroid gland that's going to destroy the surrounding thyroid gland tissue. Within a matter of, 2 to 4 or 5 months or so, you're going to have thyroid destruction. It's something that's very easy to give. It's a one-time treatment. So they take this pill or this liquid one time. It's inexpensive, and it's generally considered to be very painless. It doesn't, patient doesn't suffer from it. You sometimes need to what's called like optimize the patient before they take this radioactive iodine. You would have them. I won't get into too many details regarding this, but they need to be on like a low iodine diet. You would have them stop their thiamide a few days before, and that's so the thyroid gland is kind of hungry for iodine at that point, right? You've starved it a little bit of iodine, and it'll take this material up quickly, and then you will hopefully have the effect that you want on the thyroid gland.
Question.
Yes.
So you're saying that they would use that because it's easier to treat patients for hypothyroidism than hyperthyroidism?
Yeah, it's generally easier to treat patients who are hypothyroid versus hyperthyroid. Yeah. It's kind of a weird way of thinking about it. But, yeah. Did anybody work in an endocrinology clinic before they came here? Nobody? Yeah? Do you have any experiences from treating patients or seeing them treat patients who are hyperthyroid? I feel like hyperthyroid can be a little trickier to treat than hypothyroid.
I saw more hypothyroid.
You do. You see a lot more hypothyroid. Yeah.
Gain weight.
Yeah, hypothyroid, you'll gain weight. Did you ever see anybody being treated with radioactive iodine? Okay.
Yeah.
Do you remember why they were? You didn't.
It was a pediatric clinic.
Okay.
But then,
Okay, so you're gonna see the last list. Okay. And then this is radioactive, right? So they need to take some precautions. Once they take this in, once they ingest it, it can affect those around them, right? But there are just simple precautions, and a patient will usually be given instructions on, how many days they should sleep alone, not next to their partner. They shouldn't be around pregnant family members or friends or children for a certain amount of time, and all of these depend on the dosages that they're given. They shouldn't share things. They shouldn't have any sexual contact with anybody, again, for a defined period of time, until the radioactive iodine has kind of cleared or started to clear from their system. So we talked a little bit about indications. So the side effect, I already mentioned it, is a delayed hypothyroidism. And these patients will be monitored closely for hypothyroidism. They'll be checked, their TSH, their blood values will be checked to detect when hypothyroidism starts. And if it does, then they will be given Synthroid or levothyroxine to start. Okay, just a word on amiodarone and then we'll take a break. So amiodarone is a cardiac drug. It has very high iodine content. And that's partially why it can affect the thyroid gland. So it can, outside of the fact that it has high iodine content, it can inhibit the deiodination of T4 to T3. It can block T3 binding to the nuclear receptors, and it can also have a direct effect on the thyroid, resulting in destruction of the thyroid gland. And the reason why you should be aware of this is because these effects on the thyroid gland and thyroid hormone function can occur in up to 20% of patients on this drug. So this is my last slide before we take a break, okay? So it can induce hypothyroidism or thyrotoxicosis. And let me think of what are major points here. And so in terms of the hypothyroidism, this can happen in a patient who has a normal thyroid gland and in a patient who has underlying thyroid disease, basically. And again, here it can be easily treated with levothyroxine. In terms of thyrotoxicosis, there's two types. There's one that can happen in patients who have underlying thyroid disease and one that can happen in patients without underlying thyroid disease, okay? So AIT1 are patients who have underlying thyroid disease, and it's an iodine-induced hyperthyroidism, and you're going to treat it like hyperthyroid. In patients who don't have underlying thyroid disease, they are basically having destruction of the thyroid gland. That's going to cause massive release of thyroid hormone into the plasma, and then eventually what's going to happen to these patients? Exactly, yeah. Okay?
So they become hyperthyroid for a little bit, and then they go.
Yeah.
So
Because they're having destruction of.
So that's something they would tell you when they come to you and they tell you, I was going through this
Yeah,
and then I don't know
so-
where to go.
Yeah, I mean, so patients who are going to take amiodarone, you're going to want to warn them of this and say if you develop these kinds of symptoms, but you're going to be monitoring these patients closely for this kind of thing. Okay. So let's take a break. I think you guys are all ready for a break, right? Functions in the body, how it's metabolized, how it affects cells. You will understand essentially how glucocorticoids work as well. Really, a big takeaway in this lecture is, and I'm not going to get into chemical structures, but glucocorticoids have different chemical structures, which results in their different pharmacokinetics and pharmacodynamics. So some drugs will last a little bit longer than others because of their chemical structure, right? And this is really evident when you study the glucocorticoids. Okay, so let's get into it. Okay, before I go to the next slide, without looking. So in the adrenal gland, what are the two main anatomical?
Cortex and.
Yes, okay. Do you remember what the hormones are? Okay, let's talk about the cortex. How many zones does the cortex have?
Three.
Three. What are their names? GFR, great, yes. What does GFR stand for? Okay, good.
Ridiculous.
Ridiculous, okay.
He was holding that joke since last semester.
Appropriate for adrenal androgens. Okay, and then what are the hormones that each layer produces? Okay, so G,
Mm-hmm.
which one? Okay, F.
Glucocorticoid.
That's all you have, right? And then R is the androgens. We will not focus on R today. And then what does the medulla produce? Yes, yeah. Epinephrine, norepinephrine, all the things. Okay. So we talked about that. Again, the HPA axis rears its ugly head. So what is the hypothalamus? Which hormone is it producing here?
CRH.
Yes, good. And that stands for? Good. And then that affects the, which releases?
ACTH.
Good. And that affects? Yes. Yeah. Does anybody know which zone it affects more than the other? I will draw little schematics so you guys
Which zone?
so is it going to affect mineralocorticoid production more or glucocorticoid production more? ACTH. Yes. It's like I knew by the look on your face. Okay, so let me draw a quick little thing.
I know.
So, I'm sorry, I said mineral, it's glucocorticoids. You're right, it is glucocorticoids. Right?
You're wrong, too. You're wrong.
Oh yeah, I am.
What's affecting mineralocorticoid production? Yeah, what's the system called? Yeah, okay, good. Yes. So, let's see. So we have cholesterol as our precursor, right? And then it's going to go down. I'm not going to draw all the enzymes and names, right? But you're essentially going to end up with, I will draw just one. Let's do one. So you're going to have pregnenolone. We have the 17 alpha. This one is going to lead to, yeah. So androstenedione is the big one that, right? That the adrenal gland produces, right? So in postmenopausal women or women who have had hysterectomies, right, their ovaries have been removed, this is going to be their primary source of androgens in the body. But menstruating women, this will be a minor, this will be secondary. But we're not talking about this, just so you know you have the whole pathway in your, okay. I don't want to do this. Does anybody know what the 17 alpha hydroxypregnenolone pathway leads to? The middle one, if you remember. Okay, so this is going to lead to cortisol production. Cortisol. And then, what's the last one left from the adrenal one? Aldosterone. So before I draw aldosterone, draw just a precursor to it. Again, you don't need to memorize these precursor names. I mean, you need to know some of them, but not for this class. And and then aldosterone. Okay, does anybody know which arrow the RAS system affects? Yeah, so it's gonna affect right here, right? What's the end product of RAS? Okay, yeah, but in terms of aldosterone production, what is the hormone? Yes, exactly. Okay, does anybody know where ACTH is working in this?
It works in
The second one? Actually works here. So ACTH does affect aldosterone somewhat, but the majority of the regulation of aldosterone is coming from angiotensin II, okay? So this is a nice way, I think, to remember how the HB axis plus the RAS system affect the production of the 3 adrenal gland hormones that we want to talk about. Okay. So, is there anything else on that? All right, and then that's the RAS system, which covered. So essentially, that is like a mini version of this. Okay, which I'm sure you've grown to love seeing this. Okay. Okay, let's spend some time here. Corticosteroids. So we tend to, when people use the term corticosteroid or steroid, a lot of times they're referring to glucocorticoids, cortisol. But corticosteroid, its true definition is basically mineralocorticoids plus glucocorticoids. So it's a class of steroids. But again, just be aware that a lot of times when you're talking with other professors, clinicians, they'll use the term corticosteroids or steroids to mean cortisol or glucocorticoids specifically. So cortisol is a glucocorticoid, right? So let me put that up here just so we have our complete picture. So I'll put GC, mineralocorticoid, MC, okay? So glucocorticoid, it describes basically the class of steroids. It comes from glucose plus cortex plus steroid, and that's because glucocorticoids tend to affect glucose metabolism heavily, and they come from the cortex. Mineralocorticoids tend to affect sodium water retention, right? Okay. And then we already know the meanings of endogenous and exogenous. This is in here because somebody had asked for YouTube videos. I don't know if this is also Armando's too, but this is a great one. Okay, this was a great one to review.
Yeah.
Okay. So I just put it in there. Yeah, there's his signature. That guy, man, he's probably a millionaire. Anything in purple, I will upload new slides. There's not many, so I apologize, but I just made a few edits. So anything in purple is not on your slide. You don't need to furiously write everything. I will have Professor K upload the new slide set tonight. But I wanted to tweak some things a little bit. Okay, so endogenous glucocorticoids. And when we talk about this group of drugs, this group of steroids, we're talking about cortisol as the main one. That's the one that the adrenal cortex is producing. We already talked about its regulation, so the HPA axis. In terms of its secretion, this has a really interesting pattern of secretion. Does anybody know how cortisol is secreted in our body, or how frequently, or what the pattern of secretion is? Circadian rhythm, yes. So we have our highest levels in the morning, around 8 a.m. roughly, but in the morning. Lowest levels at night. And the reason why it's circadian is the ACTH itself is pulsatile. And so that basically causes the cortisol to be released in this circadian diurnal pattern. Also, the sensitivity of tissues to cortisol is inverse of its secretion. So when cortisol is high, the sensitivity levels of tissues to cortisol is low, and then the opposite happens. So just a way of regulating the effect of cortisol on tissues, right? In plasma, it's lipid soluble. It's bound to CBG, corticosteroid binding globulin. So hopefully this sounds familiar. A small percentage is bound to albumin. And then when cortisol levels exceed a certain level, the binding globulin becomes saturated and then the free concentration begins to rise. Again, like with thyroid binding globulin, corticosteroid binding globulin can also be affected by outside influences, estrogen, thyroid gland, hyperthyroidism. It can affect the levels of binding globulin. Again, body will auto-regulate so that the free fraction of glucocorticoids or cortisol is maintained within a narrow range. So, okay. So its half-life, an hour to an hour and a half. And then that half-life will increase if you give synthetic cortisol in large amounts. In terms of elimination, it's hepatic in terms of its metabolism, right? So we should maybe talk about this a little bit. Is it okay if I use the chalkboard? Or do you guys, I can erase this? Don't erase, okay. Let me see if I can take a picture. Okay, so what is the inactive metabolite of cortisol? What does the liver metabolize cortisol to? Cortisol, yes. Good. And it metabolizes it via the, what I heard, it cytochrome. Yes. The interesting thing is that it can go both ways by the same enzyme. Does anybody know the actual enzyme, the CYP, the name?
CYP.
Nice.
I don't know the actual CYP name of it. No, I don't think I even have it. And anyway, the name of the enzyme is, I'll put it in here, 11 beta. Yeah, dehydrogenase. Yeah, there's 1 and 2. Who can remind me which one is in the liver? 1 or 2? 1, yes. Okay. So 1 is predominantly in the liver. That's like the main one. It's also in fat, bone, I think skin, in the eye. You guys don't need to remember this stuff, but just for me. Okay. So, is it 1 that causes cortisol to cortisone? Yes. Okay, so 1. That's the one in the liver. 2, 11 beta dehydrogenase 2 causes cortisone to go back to cortisol. Okay? Does anybody know where 2 is found? Yeah, kidney. And then colon, salivary gland. underneath the placenta too, which is an interesting thing. Okay. So we'll come back to this in just a bit, but cortisone is also actually a synthetic, it's synthetically made as well, right? And the synthetic cortisone also needs to be metabolized by this enzyme to be an active drug, an active metabolite. Would you, okay, I'll stop there. Okay. So, I think I flipped them. Okay, I need to check on something. 1 second. Review your slides. Review your slides. What's that? Yeah, you said it. Say it again.
Gene expression.
Okay, good. Say it loud. Everybody here. Loud and proud. So yes, same thing. Okay, as thyroid hormones, it's going to basically cause gene expression. The interesting thing is that it's estimated that cortisol may regulate or affect 10 to 20% of all gene expression in our bodies. So if you just think about that for a second, you can think of how grand of a hormone cortisol is, right? And why it's talked about quite a bit by everybody. Okay, so I'm not going to get into details of this, but essentially knowing that like thyroid hormone, it's going to affect gene expression on a cellular level. Mineralocorticoids. So aldosterone is the one that we focus on in the mineralocorticoid group. And exactly like cortisol, it's going to bind to cytoplasmic receptors, receptors within the cell, activate them to move into the nucleus and eventually affect gene transcription. Okay. So this is just a schematic that you can look at, but it's essentially a listing of cortisol's effects on the body. Almost every single organ system is involved. The ones that I'm going to highlight, so it's metabolic effects. So cortisol obviously can be released during stressful times to help with maintaining energy levels. It will increase gluconeogenesis. It'll reduce glucose uptake so that glucose and that energy can go to the organs that really need it during stressful times. Chronically elevated cortisol can do what? Yeah, it can affect weight, fat distribution in the body. Its effects on the immune system are also pretty widespread. I would think of it really as being an anti-inflammatory agent. I listed some of the details of how it can affect the immune system. But essentially it has a big effect on the immune system in terms of being anti-inflammatory and immunosuppressive as well. Okay. So why do we use synthetic steroids? Glucocorticoids, basically. So what are uses of steroids that you've seen? Reduce inflammation, and what kinds of like patient situations have you seen it where it reduces inflammation?
Skin diseases.
Yeah, skin is a big one. So certain rashes, right?
Asthma.
Asthma is a huge one. Respiratory, exactly, right? So people who have asthma or reactive airways, right, when they get sick and their immune system seems to be on hyperdrive a little bit. What's another huge category of diseases that we use it for anti-inflammatory immunosuppressive effects?
Arthritis?
Yeah, and arthritis falls into this category. Yes, arthritis. What is this category of disease?
Autoimmune.
Yes, autoimmune diseases, rheumatology. So in rheumatology, we will talk about steroid use a lot. And the answer to what is treated with, what do you use to treat this disease will most of the time be steroid. especially in the beginning stages of treating a disease. We'll use steroids to kind of calm things down, and then we'll put patients on immunosuppressive agents that will decrease the chances of getting long-term effects from chronic steroid use. And then, that will maintain kind of the suppression of the immune system that the steroids started and we're able to do quickly. Okay. So I'm going to talk a little bit about the differences between synthetic steroids and cortisol, basically what's produced naturally by the body. In terms of its mechanism of action, it's pretty much the same. But what has the differences come from, like I mentioned earlier, the chemical structures of these synthetic glucocorticoids have been changed to affect how well these steroids bind to both glucocorticoid receptors and mineralocorticoid receptors. I saw a hand, no? Okay. It also has affected the half-life of these synthetically made steroids. So half-lives are generally longer than cortisol, which is what you would want, right, when you're giving a synthetic steroid because you're trying to treat something. These steroids, what kind of forms are they available in? What formulations have you seen these steroids being used? So it's like topical, injection, inhalers. In terms of topical, you can see them as cream, ointments, shampoos, you name it, you will find it. Okay, nasal sprays, right? If anybody has allergies. So they are rapidly and completely absorbed. Topical steroids are also absorbed by a normal intact skin, and it can have systemic effects. Topical steroids can have systemic effects. They are bound to plasma proteins. They're largely bound to albumin, whereas endogenous cortisol is largely bound to CBG, right? Yeah, okay. So exogenous are going to be largely bound to albumin. They're metabolized by the liver and excreted by the kidneys. So this is a slide that you guys don't have, but it's in the book. And this is a slide that, this graph, you will see it almost everywhere. But these are, we like to split up synthetically made glucocorticoids by how strong of a steroid they are, right? So you'll see that on the left side, the short to medium acting, intermediate acting, and long acting steroids. Hydrocortisone, you can buy it over the counter, right? Has anybody ever bought it? Yeah, and what have you used it for? Itching, rash. What's that?
Yeah, for skin.
For skin primarily, yeah. People will also buy it for, anybody know what else here? In the rectum? No? Anusol, it's called Anusol HC. No?
Oh, yeah, that's used
For what?
Is that
For hemorrhoids, yes. Yep, yeah. So, and then basically how I would spend a few minutes learning this chart. So you'll have that column of the agent, right, that's broken up by how strong the medications are, and then its activity. So how anti-inflammatory it is. Topical, you don't have to focus on topical for this class, but anti-inflammatory and salt retaining are the two for this class that you really want to focus on. How anti-inflammatory is it, and how salt retaining is it? So fludrocortisone, which is one at the bottom right here, is under mineralocorticoids for a reason, and that's because its salt retaining ability is much higher than the rest of these drugs. These numbers are in reference to cortisol, right? So if cortisol, which is hydrocortisone, is given a 1 in terms of its activity level, its anti-inflammatory level, its salt retaining level. So let's look at fludrocortisone. It has the highest, when you compare it to cortisol, is 250 times more salt retaining than cortisol, okay? So I would spend some time and just familiarize yourself with how to read this graph. It can look daunting, but it's not. So you can see that all these have no salt retaining activity, right? This huge group with zeros. The rest of the glucocorticoids really have very relatively little salt retaining activity, and that's why they're considered glucocorticoids and not mineral. Okay, and then you can do the same for anti-inflammatory category, basically. Does that make sense? Yes. Okay. So those would be the three basically columns that I would look at: salt retaining, anti-inflammatory, and the agents. Okay, so let's take a look at a few select steroids. So again, the wording on my slide wasn't very clear. Hydrocortisone is the synthetic analog of cortisol, right? So cortisol is the one that's naturally occurring. People will call hydrocortisone cortisol, and they'll mean the cream, or they'll mean the drug, right? So it depends on the context in which that conversation is happening. But just be aware that hydrocortisone and cortisol can be kind of simultaneously used to mean each other. To physiologically replace cortisol in the body, you would give about 20 to 30 milligrams per day, and you would divide it into BID twice a day dosing to mimic the circadian rhythm of cortisol, right? With a little bit of a higher dose in the morning than in the evening. It has minor mineralocorticoid activity, salt retaining activity, right? So it's a 1 on the salt retaining scale. Cortisone is naturally produced, right? And I will clarify the enzymes and then get back to you guys on that. And it's also synthetically occurring. It's inactive. So both the synthetic and the one that our bodies produce is inactive. It needs to be metabolized to cortisol by 11 beta dehydrogenase, either 1 or 2. So the liver has 1 to become an active glucocorticoid. Okay, prednisone. Prednisone is very widely used, especially in rheumatology. It's one of the, I think, the biggest steroids that we use in terms of steroids that are not super strong, but so asthma you'll see it being used quite a bit. So its half-life is a little bit longer than hydrocortisone. I put down the physiologic dose, so what it would be equivalent to cortisol physiologically. It has high glucocorticoid activity, low mineralocorticoid activity. So again, just going back to that chart. It's also a prodrug, like cortisone. So it has to be converted in the liver by the 11 beta dehydrogenase enzyme to its active metabolite prednisolone. Okay. So kind of a similar theme here in terms of cortisone and prednisone. So if you wanted to, you could even add on here. Prednisone to prednisolone. Okay. So if the liver is the one that has the majority of type 1, right? So type 1 is the one that's going to convert cortisone or prednisone to cortisol or prednisolone. If you have somebody who has liver failure or liver damage or liver disease, would you want to give them cortisone or prednisone if you're trying to get a steroid effect? No, because they're not going to be able to metabolize it to its active metabolite, right? Okay. Okay. I listed a few more here: methylprednisolone and dexamethasone. These are a bit stronger. Again, just things you can review, and the points that I've listed here are also in the table.
Dr. Shabbat?
Yes.
Would you need us to remember 11 beta hydroxysteroid, as far as
no, I mean I won't tell test you
Okay.
on that particular enzyme.
Okay, good. Just
But
check.
I think being aware of it is important.
Okay, cool.
There was a point that I wanted to make, I think, let me see if I can. Yeah, in the placenta, I think it's on this slide. So the placenta expresses this same enzyme, 11-beta hydroxysteroid dehydrogenase, which inactivates cortisol and prednisolone, right? So placenta, I think, is supposed to be in 1. This is the point that I wanted to. Sorry. No, it isn't 2. Basically, so the enzyme that the placenta has plays a protective role. If you were to give a patient a steroid, the placenta has high levels of the 11-beta dehydrogenase enzyme, which will inactivate the steroid so that it doesn't have an effect on the placenta, on the fetus, basically. But this is the point that I want to clarify before I tell you guys which one it has. So I think I'm confusing the 2 types in my head. Okay. This is the type of enzyme is not something that usually, you would use this information in clinical practice. And you just kind of know which steroid to give and which one to not give. So. Okay. So methylprednisolone is exactly like it sounds. It's a methylated analog of prednisolone. It has strong anti-inflammatory effects. And like I mentioned before, these are all within, basically the points that I'm making on this slide are all within that graph. And in terms of the graph, I would know, again, trends. So which one has the highest salt retaining characteristic? Which ones have kind of the higher anti-inflammatory properties? Which ones would be considered low anti-inflammatory on that scale? We'll talk a little bit about fludrocortisone. So its structure is very similar to cortisol, except it has a fluorine atom, and that's why it's called fludrocortisone. And that fluorine atom is what allows it to have a really high salt-retaining activity, high mineralocorticoid activity, and also prevents its renal inactivation by that same enzyme. So it's used to treat Addison's disease. Again, something you guys will learn about in endocrinology. Okay, let's talk about side effects. So, kind of without looking at the slides, what are some of the side effects that come to mind when you think of glucocorticoids or steroids?
Thinning of the skin.
Thinning of the skin.
Weight gain.
Hyperglycemia. And hyperglycemia leading to, if you use it chronically, diabetes. Yeah. Okay, so what else? Weight gain.
Leukocytosis.
Okay. What's that? Yeah, so even short-term prednisone use or steroid use, patients will tell you they have weird dreams or they can't sleep or they just feel off on steroids. They feel weird. So I like to think of side effects as those that can happen acutely with steroids and those that can happen over a longer period of time of steroid use. Less than 2 weeks. 2 weeks is kind of the time frame that we think of when we go from kind of acute to more chronic use of steroids, and we'll get into that in just a second as to why it's 2 weeks. But less than 2 weeks, more acute type of side effects would be insomnia, so lack of sleep, behavioral changes, peptic ulcer disease, so having more reflux or irritation, right? And then in terms of greater than 2 weeks, you have a whole host of things that can be caused. All of them are reversible except for 2. Does anybody know which 2 are not? It would require, kind of medical intervention besides just stopping the drug. So one is cataracts. Long-term steroid use can cause cataracts. And the other one is aseptic necrosis of the femur, basically. So you can get necrotic tissue in the bone. Okay. So just another, so in this graph, the ones that are bolded are the ones that I would for sure know. And the ones that are red are the ones that are irreversible if they do happen. It lists the mechanisms of action for these side effects. I think just kind of being aware, and it's there for those who may want to tie loose ends together too. There's a mnemonic called Cushingoid. Have you guys heard of this mnemonic before? Yeah? Okay. I put it there. If you like mnemonics, you can use it to help you remember the side effects of glucocorticoid. There's Cushing's disease and Cushing's syndrome, if you guys have ever heard of those. And they're basically diseases that are related to excess steroids or cortisol in the body. Okay. So this is the point that I was making about 2 weeks. So when you start to use steroids chronically, you will suppress the HPA axis. And what's the concern there if you're suppressing HPA axis? There's kind of two big concerns. So one is during times of stress, you're going to have to remember to give the patient more steroid, right? Because their body now, their adrenal gland is basically unable to produce more steroid that it needs during times of stress. And then the second one is when you stop the drug, what could happen?
Like you just rush it.
So, sorry, I heard lots of things at the same time. Okay, in the back. No? Okay, fine. So what's essentially going to happen if you suppress the HPA axis and now you've stopped this patient's steroids?
Hyperactive, right? It's just gonna.
No.
No.
Weak immune system.
Okay, but what happens to the steroid levels in the body?
It's gonna be low, and like
It's
it's
going to
not
be very low.
because it's not
Yeah.
producing it itself.
It's not, adrenal gland is unable to produce it. So what do we have to do with patients who are on steroids for a long time?
Taper.
You have to taper for this reason, okay? So you can cause adrenal insufficiency and even adrenal crisis. And so you have to gradually wean them off. Everybody seems to have their own schedule as to how to wean off steroids. The longer a patient is on a steroid, the slower you're going to wean them off of it, basically. And you can have people who are on a schedule to wean off that's over months, where they remain, maybe they were taking really high doses of steroids, and then now they're at like 5 milligrams of prednisone, and they stay on that for a long time until their adrenal gland starts to kind of wake up a little bit. So it can take up to a year for the HPA axis to start working again. And that's why some patients will be on these low doses of steroids for a long time. So contraindications for steroid use, basically if you have a systemic infection. But really, besides that, you're going to use steroids in so many situations. So it's really more you want to be cautious in patients who have really any kind of chronic illnesses, are weak because of something happening to their body, whether it's heart disease, diabetes, just older age, whatever it is. So we talked a little bit about indications, but again, just showing you how widespread in terms of almost every organ system, every disease states that are out there, use steroids. I put in a little bit of the indications for use. What do I want to say about this? So just to kind of give you a sense and a flavor of how widely steroids are used. So we will use steroids. We will give steroids to pregnant moms who may be at risk of preterm labor to help speed up the development of the lung in the fetus. We will use it in basically if there's adrenal insufficiency, so the adrenal gland is not able to produce enough cortisol, we will give synthetic steroids to make up for that. Let's see what else I want to say about this. Nothing here. Again, stuff that you guys can look at. Okay. let's talk a little bit about antagonists. There are a few drugs that are listed in the textbook as antagonists to glucocorticoids. These are not, they're very rarely used as glucocorticoid antagonists, but again, just being aware of the potential effect that these drugs can have as antagonists is what I would get out of these slides, basically. So mifepristone, does anybody know what that drug is? Terminate pregnancy, yeah, exactly. So it also has a glucocorticoid antagonist effect on the receptor. Ketoconazole, anybody know what that drug is? Antifungal, you guys have studied it, sounds like. It also is a potent and non-selective inhibitor of the enzymes that cleave cholesterol to form cortisol. And etomidate as well. Okay, let's talk about the antagonist for mineralocorticoids, spironolactone, because this drug you will see being used. So it has a slow onset of action, and it lasts about 2 to 3 days after the drug is stopped. It competitively antagonizes the MR receptor, the aldosterone receptor. It is used for basically in heart failure. It can be used for hypertension, but its biggest indication is in heart failure. It also has anti-androgenic effects, so it antagonizes the androgen receptor as well. So sometimes we use it in hirsutism, which is, does anybody know what hirsutism is? Excessive hair growth, exactly, yeah. And acne, so it can help those two. The biggest side effects, hyperkalemia is a big one with spironolactone. Gynecomastia too, which is large breasts. Yes. And there's another one, epileurinone, and it's similar to spironolactone. Okay, so that's it. And we're done. A little early. Good. Does anybody have questions? Yes.
I'm looking at emails you.
What's up?
I'm looking at emails you.
Oh, yeah. Okay, let's talk in a few minutes. Anybody have questions? No? You guys are free.
Flock away.